Okay, so let's say you've come to some kind of diagnostic approach and sort of decide that, okay, here's someone who's got some early degenerative changes in the neck, maybe a little bit of facet arthritis, maybe a lot more kind of myofascial things. Next steps, what are your next steps in treatment at that point? And then how does that escalate as needed?
So what I would say is, originally I used to be like, all right, we know what the targets are, let's go get them, right? We're tip of the spear, let's go get it, right? But now I think it's different, because the question I think that is really critical, and you asked it in a different context earlier, is why? And the piece would be, is so why do you have that facet disease? Why do you have that myofascial problem? And the major reason for that is, so let's say that we intervene and we quote unquote fix that problem. How do we know it's not going to be recurrent? So what we really need to get to is, let's ask a few more questions. Let's do a little bit more in terms of exam and understand, is that degenerative course just because it is wear and tear? Or could it be something else that may have caused that we need to address? Because if we don't, well, it's just like you've plugged a piece of cement in the foundation, but you never figured out that you actually had a sinkhole that was going on. Let's deal with the sinkhole and make sure that we're not missing something else in order to be able to kind of address this.
Okay, so let's say you've taken that step. Give me the next steps.
Okay, so fine, we got facet disease. We know that there's nothing that's ominous. It's kind of general kind of wear and tear. So then the question would be is, so when I do cervical hyperextension, can we be able to elicit that pain? Assuming you don't have any whiplash, nothing that's taken place from a motor vehicle accident, anything along those lines. You've been through physical therapy. You've done some of those things to be able to try to see what you can do. And you've tried to do other type of things that have kind of really tie in with physical therapy, meaning you've done things that have tried to address fascial layers, the things that you might have considered maybe doing some dry needling perhaps. Maybe you've done some postural restoration. Maybe you've done some red cord type therapy, all those type of things. Perhaps at home you've considered doing some things where you've done like inversion table or something along those lines to see if you can get some degree of benefit. Then what we're talking about is seeing, does that facet disease stay right there localized to the axial spine, or do you potentially have some radiation? Because cervical facets can give you radiation into the aspect of the shoulders, into the scapula, those type of things. And if that's the case, then what we really want to do is to try to look at how can we be able to use an orthobiologic type treatment to be able to intervene and give you something that's going to be sustainable. You know, I think many pain docs would have traditionally said, let's do diagnostic blocks, let's maybe use steroids. But the fact of the matter is, what we want to do is to try to get that back to its natural state. And so that's really how we want to go about trying to treat it.
You know, it's interesting. Diagnostic blocks, they make a lot of sense in theory, right? And in some cases, if someone's pain is really truly coming from just that one structure, that makes a lot of sense. But the reality is, it's always more complicated. There's always multiple layers. And so you use the term orthobiologics, great term, right? Referring to a lot of your cell-based treatments, a lot of times your own cells, including platelets or bone marrow-derived stem cells, to help treat orthopedic musculoskeletal conditions. So let's say first-line treatment, have already gone through physical therapy, posture correction, some other basics. What is the first-line orthobiologic you would use for a neck issue?
So, I mean, if we're starting from the very, very basic and we're not even including kind of that biologic piece, I think what fits into the whole spectrum of it is the context of us looking at that aspect of traditional prolo, you know, before we get in. And so that prolo piece has a wide variance, right? So you could talk about traditional prolo. You could talk about whether you have that with the aspect of platelet lysate that's combined in connection. And in that context, what we're talking about is that aspect of the tendons and the muscles and how they relate to the elements of how they connect into the spine. And I think that that's an interesting piece. I think from a facet standpoint that we talked about earlier, when we start looking at that intra-articular components of facet kind of going from that zygapophyseal joint, that face of that joint is, are we starting to have some changes in the cartilage that's present there? If that's the case, then we're probably going to step it up a little bit and look towards something that will fit within the model of kind of PRP or platelet-rich plasma. So those would kind of be the two things that we'd kind of be making a decision about in that entry level. And more than likely, it's probably a blend of both.
I got briefly disconnected, but I heard you talk about as an intro level, you're thinking prolotherapy versus platelet-rich plasma. In your experience, when it comes to spine-related things, number one, how do you decide between one or the other, right? Someone who's got, let's say, mild to moderate pathology, how do you decide which one to start treatment with? And if you start with a lower level treatment, in general, how would you approach that? Would you say give it a couple of treatments? Would you say give it one, see what happens? What's your general treatment algorithm or approach to that?
Yeah, I think the answer to that, and not to be political and avoid the question, but I will tell you, to me, I think it's very personalized. I think that you have to tailor the treatment to the person, right? So what I might say in one person will not be the fit, even if you have the same clinical presentation. It's really going to be about what's your functionality, where you're at, and what's your mindset to an extent too. So I think we really have to get clarity about all those type of things. But in answering your question, I think, so let's say that this is not making a major impact on your life. Let's say that you say, you know what, it's bothering me. It's a nuisance, but it's not making me have to say I am grimacing in pain consistently. Then it kind of gives us an idea that maybe we start at a low level. And then we see how that works in conjunction with things that you are doing autonomously, meaning your own exercises, influencing your kind of biopsychosocial level of things that surround you. Can you change your pillow? Can you change your sleeping habits? Can you do other things to be able to improve that? And then see how we're able to step it up. If someone says that, you know what, I am in debilitating pain, I can only sleep maybe an hour, a night, I can't be able to function at my job, I have, just deficits that are causing me all types of problems, then we look to potentially scale that. If someone's had this problem for a number of years and they're like, I've tried everything, I'm tired, let's see what we can do to be able to intervene, then that's how we're going to kind of look towards what that scale happens to be and how we would be able to treat.
Yeah, that makes so much sense. That it's never going to be a hammer hitting a nail kind of approach. It is always going to be such a personalized, individual based approach based on goals of the patient, based on degree of pathology, what have they tried, how limited are they, and all their other kind of medical issues always has to be considered as well. Okay, cool. Okay, so then, so we've talked a little bit about prolotherapy, platelet-rich plasma, platelet lysate. Give me a sense for when you would actually escalate to even something stronger, like let's say bone marrow aspirate concentrate or bone marrow-derived stem cells.
Yeah, so I think when we talk about neck pain, we haven't talked about, or at least I haven't talked about in depth and detail, what are some of the pathology. Let's say we move muscle aside and we'd say it's not facet. You can have cervical radiculopathy, which can be caused by a number of different things. It could be caused from a herniated disc. It could be caused because you have a foraminotomy, rather the foramen is actually decreased in size. Perhaps you have some degree of cervical instability that causes you to have a shift and have other problems that's in place. It could be ligamentous in nature. It could be discogenic, meaning it's within the context of the disc itself. So, and outside of that are things that would be more neurologic. So you could have a brachial plexus component, you can have cervical plexus issues, you can have occipital neuralgia, all those type of things all have an interplay between the head and neck component that give you things that you need to really kind of assess. So when we talk about looking at the aspect of bone marrow concentrate as a potential utility, really where I kind of see it having a great fit is when you have severe facet disease or when you have disc issues that need to be addressed. Can you be able to deal with it from looking at utilizing something called platelet lysate, which is similar to PRP that has a different variant and form to target and be able to surround the nerves and give a much more robust but less caustic response to traditional PRP? Yes. But when you talk about looking at intradiscal and facet pathology, which is severe, sometimes it doesn't respond to just PRP. It doesn't respond to platelet lysate. And at that point in time, then you're talking about using a more aggressive treatment in order to be able to get a much more improved therapeutic response.